I'm Andrew Freed.
My name's Dave McKenzie.
We're from Maine Medical Center. Happy to be here to tell you about kind of the logistics of starting a TEE program.
And thank you for choosing us before your Sono Games experience.
That's right. So what we're actually not talking about today is kind of the why of doing TEE and cardiac arrest. There's a lot of resources out there. There's some great literature. There's courses to go to that'll kind of give you the background of why this is so important. I think probably the easiest way to grasp why it's so important is to go to a code where someone's doing TEE and just kind of find those immeasurable benefits and that feeling of calm that kind of overtakes the room. But we're not going to focus on that today. We're also not going to focus on how to do a TEE, how to get those views, how to interpret them, acquire them, and what to do with that information in a code. We're really going to focus on building a program, what our experience was, what we did well, what we didn't do so well, and all the things we learned along the way. I know, depending on what kind of hospital you're at or what your practice is like, this may seem like something that's far off in the future to many people. But just keep in mind that as fellow geeks that know a lot about cardiac arrest, we've been putting tubes in people's GI tract to try and treat cardiac arrest for 400 years now. We've changed from the rectal tobacco smoke to now an esophageal TEE to try and get better views of the heart, but it's come a long way.
And I think one thing to keep in mind is it wasn't so long ago that even a machine as sort of awkward and cumbersome as this seemed like a futuristic addition to have in the ED. And so even if you're kind of at the contemplative or pre-contemplative phase of bringing TEE into an ED, I think there's clearly a drift that this is where we're headed, and a lot of great data that supports why we should be doing it.
One other thing, Dave. That being said, it also takes a lot more time than you think. So if you think, oh, we're not there yet, but we might be there in 5, 10 years, start having these conversations. Start talking to your chair. Start talking to the other people in your hospital, because this took us, to go from the idea of presenting this to the chair to having a TEE probe that is being frequently used on shift. It's a good 3-4 year process.
One of the other things that, as you get started, makes sense to do is just to try and get the lay of the land through discussions and figure out who are your allies. And you'll probably have some opponents as well, too. But figuring out who your friends are is an enormous step in trying to build out a program, because if you have resources in-house that can help you from the perspective of machines or training, it makes your path tremendously easier. And so having discussions with other users in your hospital to figure out who might be on your side, and it may not even be at a department level. A lot of times this is actually right down to the level of an individual. A single person in one given department can really help swing things for you, and having that person as an asset is key. So networking and having relationships outside your department, I think, is critical to success in many domains, but that holds true for TEE as well. You may find that person in anesthesia, you might find them in cardiology, you might find them in critical care. You may have allies from all those departments, as well as detractors that exist within the same department, but one invested person who is already doing TEE will carry you forward tremendously. So there's no need to reinvent the wheel. Find someone who's doing something that you're familiar with and have them help you out.
Yeah, and as Dave said, that goes from the training level to performing these all the way down to like sterilization processes, like getting these things that are already in place and just kind of latching on to things that are known. So our experience was less finding friends and more finding people that were indifferent. A couple detractors, but for the most part, we were kind of on our own. We reached out, said, we want to start doing this. Who's going to help us? Who's going to teach us? Who's going to get us into the OR to get these studies? Who's going to help our residents train? There was a lot of radio silence to like, what are you doing? What are you trying to do here? So if that's the case, which is often the case, you need a few things in your court. You need a chair that's willing to kind of help with the funding and help with those emails when inevitably someone finds out, even though you told them 2 years prior, you're doing what downstairs? This is our thing. Someone to have your back. And then you just need a couple big ticket items in the budgeting process.
So depending on what your experience with ultrasound has been, if you are relatively younger career, you may find that you get to live out the experience that sort of the founders of point-of-care emergency ultrasound had to do. So if you've never fought a battle surrounding the ability to perform or use a new application or to get a device, you may get to relive the 1990s or 2000s all over again. And that may be an interesting experience. And it can be valuable to talk to people who are more senior about what their experience was like and if there were strategies that made sense, particularly within your hospital setting. And that may be someone who is now in a different role. They may have moved up in administration. They may have even gone elsewhere. but they may know some of the personalities and players and sort of some of the disposition or bent of the people who might oppose you along the way, whether it's at the level of hospital privileging or someone administratively or any of the channels if you need to access funding. You don't have to do it from scratch, but do realize that you may get to recapitulate this experience that you've heard other people talk about how difficult it was to get a machine to be able to do a fast exam or something like that.
Yeah, so and once you do get this going and start having those conversations, your best defense against those opponents is really just to have clearly written out, public, shared, documented policies of exactly what you're doing. I would say this is probably one of the things that we did right, among many that we did not so great, but having this out there from the very beginning, as soon as we decided we wanted to do this, sharing this with cardiology and anesthesia and critical care, they kind of take a look at it and say, oh, okay, fine, then they forget about it. But then 2 years later, when they hear that you're actually doing these on their patients and they see it in your department and they start sending emails, you say, yeah, here's our policy, you looked at this has been around for 2 years, and they kind of swallow it and they get excited for you, and it all goes down a lot easier.
There's an axiom that if you don't write your policies, someone else will for you. And I think that's very true. And so they become both your sword and your shield. And because there is a lot of indifference, because people are busy, until you start actually doing the thing, paper carries a great weight. And if you can point back and say, oh no, this was documented as being drafted and approved by our department, 18 months ago, they're like, oh, So you want to get it ahead. This is something you can do early. It's like you can write the methods of your paper even before you've collected any data, if you've set it up well. It's the same that holds true for this. You want to get this down in writing.
Yeah, the next thing you want to do is keep an eye on your scope of practice and make sure that is clearly written out as well. You need to watch out for indication creep here, right? And we'll talk about that a little bit in a moment, but it's a lot easier to tell cardiology why you're doing this if you let them know exactly what patients you're doing it in. It's usually a patient or population they're not very interested in.
Yeah, and it gets hard because as your program gets more mature and you're doing more of these studies, people will come to you and say, can you do a TE in this patient? And I think it takes an enormous amount of discipline to say, we're not going to do that. That's not what we have decided how we're going to use this, because that's where you start getting in. There's the potential for more trouble, I think.
So a specific thing to talk about on that point is that we only do this and I would encourage you, if you start a TE program, to write this out. This is only for intubated patients that are either coding, or we put in our protocol peri-code, so that patient that's kind of in and out of coding and has inadequate TTE views, we wanted a little bit of wiggle room to be able to do it in those patients. But what you want to fight against is a attending coming up to you and saying, this patient, we need to rule out dissection, they have a contrast allergy, can you do a TE? That is not what we're looking for. We're not looking for vegetations and endocarditis patients. So just write that out clearly and beware that as soon as people hear you can do this, they're going to ask you to do it in things that really we should not be doing it in.
And then if someone comes to you and says, hey, look, we think that, we can do this for you. The nuclear option is always there to say that if some other service, probably cardiology, says you shouldn't be doing this, then you can say that's great. This is you can come down and do it. It's very clear that this improves the care of cardiac arrest patients, and if you can commit to doing this 24 hours a day, 7 days a week, in a revenue-neutral way, you're welcome to it. I mean, you're experts in doing this. You have the experience. If you can do that, fantastic. And they just won't, they're not going to commit to being able to do that. Certainly not in a way that doesn't involve more FTE or more resources. And if you can say, look, I just need the equipment, which we'll come to in a moment, and then my people will do it, then, that's how it's going to be. But if you can commit to provide that level of service, then go ahead. I mean, we're not going to stand in your way.
All while teaching our residents, because we want them to graduate with this skill that a couple of years from now will be very important.
Right, exactly. So that's the other thing as well, too.
Next thing to do is to decide exactly what views work for you in your hospital. So when we learned this at our shop, we learned 4 views, and not to get into the details, but one of them was a bicaval view, which is very helpful for cannulating for ECPR, which is not something we do at our hospital. So we quickly learned we need to throw out that view. We actually added a different view that has been immensely helpful to look for saddle PE or dissection in a coding patient. So just find what works for your hospital with your resources and make a custom protocol that fits that. All right, getting to some of the real details here, your shopping list. It's quite frustrating when you get home from the grocery store and realize you forgot the eggs and you got to turn around. It's a lot worse when you have to go back to your chair who just got you a $40,000 probe and say, I forgot that we also need a cabinet and a leak tester and some bite blocks, et cetera. So things go better if you can all budget for them at the same time, the same kind of financial or fiscal year, and the same ask. so that works a lot better. So try and get all your ducks in a row so you know exactly what to ask for. And you always save when you bundle, right? So the cheapest way to get a TE probe is to ask for it to be part of a package when you're getting a new machine. So when your program is up for a new cart, that's when you start, that's the best time to start having these conversations about getting a TE probe thrown in. What probe to go with? You really need to go with a probe that's going to work on your cart. So if you have one type of cart in your ER, that's what you're going with. Not a lot of wiggle room there. If you have a couple different types of cart, if you have a Sonosite or Philips or whatever, then you may want to go with a probe that fits what other people in your hospital are doing, because that'll streamline sterilization processes. So if all cardiology uses Philips and you have either option, go with that. That'll help make things a lot easier on the back end. If they have a lot of brands and you have a lot of brands, one more thing and the cost here is probably somewhere in the realm of 40 to 60 grand. If you have all of the options of what probe to go with, it makes sense maybe to go for something with a little smaller footprint. These rooms get busy. We have learned pretty quickly to always have a second cart in the room, just because inevitably you're going to get some views, and then someone's going to want to put in a central line or an A line, or look for lung slide or a AAA or down the belly or something. So having a smaller footprint can be helpful, but really the most important thing is that it's compatible with what you're already using. After you get a probe, the next thing you're going to want is a second probe, because one's going to break or be down getting sterilized, or God forbid get lost, and you're going to have another code come in. So if you can budget for it, try and get a couple, but one is all you need to start off. Bite blocks are incredibly important. If you don't buy bite blocks, you'll be buying a second probe quickly, because these things can break, especially with teeth. These are really cheap. There's really no excuse, so make sure you have these. And then a cabinet with a HEPA filter. So a slightly bigger ask. In comparison to the probe, it's not huge, but it's nice to have them all packaged together in your initial ask. This will run you $3,000 to $4,000 or so. It needs to be somewhere close to your department so that you can get the probe when someone's coding. It needs to be near an outlet, so just a couple things to think about in the layout of your department and how to manage all this. Then you're going to need something to clean the probe up when you're done. We have these kind of cinch sacks. They're once again, not an expensive item, but just something to think about so that your ask can be complete. And then finally, a leak tester. So this was another surprise item that I wish I knew about before. If you have the same probe type as other people in your hospital, then you won't need to get this. They already have this in sterilization. We had to go with a different brand, so this was just another little ask at the end of the day. But it's another $2,000 and something that certainly comes off a lot more slick if you have them all together. Finally, a simulator. These are very expensive. They run somewhere between $100,000 and $300,000. Hopefully not something you have to buy, but something you really probably need access to if you're going to have a sustainable TE program. High-fidelity simulation for TE is incredibly helpful. It is really the best way to ensure that your residents, your faculty, are getting enough reps on this in between the kind of the opportunity to go into the OR, which is the best possible way, but in between those, to be able to get lots of reps with different pathology, this is something you're going to need access to. All right, so your overall shopping list is probe and or probes, a cabinet, bite blocks, cleaning kits, a leak tester, and then some type of access to a simulator. Then going about getting trained. This is some people have a lot of questions about. ACEP does have a policy statement saying that this is something that they support and something we should be doing, and their kind of guidelines for how to get trained are, in someone who's already TTE competent, you need 2 to 4 hours of didactics. That's easy to find. You need 10 proctored TE exams, including in probe insertion in live patients and simulation patients, which is purposefully left a bit vague what that 10 means. And probably the best way to go about getting these is to either know your allies in your institution and or do a commercial course that they have available, and then the standardized assessment by a credentialed TE provider. So this is how we went about doing it. I went to a course during my fellow year, got trained. Luckily, we have access to a TE simulator, and then kind of our mantra, instead of see one, do one, teach one, was more of like sim one, sim tons, and then do one. We just got a lot of reps on these, a lot of time teaching residents, teaching fellows, teaching other faculty before we got down to doing these.
And then you don't want to get away as you start rolling out a program this from the things that we know actually work in cardiac arrest. So that is, we got to do high quality CPR. And if there's a shockable rhythm, we need to address that. These are the core things, in the excitement surrounding TE, after you've gathered your supplies and you're at the point of first doing one, we really don't want to lose sight of what really matters in cardiac arrest, and that gets really important. And there will be distractions. You put this big new shiny machine in the room with nice images, the team is going to get pulled toward that. And so dedicating someone to, feed them data, but, directing them to make sure they're doing the core things well gets really important.
Yeah, and that just comes down to preparing your team. I will say people have adopted to this faster than most. Change in medicine is hard, but people seem to really like this. Nurses, techs, RT, all of a sudden they're watching the heart throughout the code. It's really kind of a calming influence. But all of a sudden you're going to be feeding back kind of different advice on what you see than they may be used to. So they're seeing asystole on the monitor. You're telling them to shock because you see fine VFib on your TE. That's a change, right? Or they don't feel a pulse, and you're saying this EF is clearly compatible with some perfusion here. Let's hold compressions. Those are changes that take some time to get used to. So just prep your team for that.
I think, too, the other thing is you can't overlook, in addition to giving the docs and the rest of the room, feeding them information that they may not be uncomfortable or may not be comfortable with. They think this is end of code. They may see organized activity, and just having them be comfortable with the idea that you can still terminate resuscitative efforts if you think it's futile, but realize that you're going to have different things that you weren't expecting to see necessarily. This also holds true for nursing. So I think nursing sometimes will get quite uncomfortable if there's something new in the room that they haven't heard about, especially something that's as big and overt and potentially in their way. And so having everyone understand that this is coming, and some in-service education or awareness for nurses actually is fairly important too. Techs or CNAs also probably need some education. If you can bring them into the processes surrounding sterilization, for instance, or if your cabinet is remote, if they're going to be the ones to help bring the transducer potentially in a code and giving them some exposure to that, all that is part of getting a successful program started, and so everyone is aware of what's coming, not just for some of the data that you're going to see, but some of the logistical factors.
And then on top of that is doing it somewhat consistently. If you have it once every 4 months, it's always going to seem like some novelty, right? So if you can try and find a way to do this somewhat consistently, something that people look forward to and can maybe even depend on, that's going to go a long way.
In keeping with that, the success of a program like this, like so many ultrasound programs, does relate to a champion. And developing a champion, I think, is critical. Having someone who's mission-focused, who is really dedicated to the program, is probably the best way to get this off the ground. At our place, that was Andrew, who took the lead on this and really brought this forward. And so having someone with the commitment to say, I'm going to help get the training done, help get people get their first experiences in SIM and in a live patient, or in this case, a coding patient, really is central to making this work. And I think that's been true of ultrasound programs, regardless of application, since time immemorial, and it's true here too.
It's really the perfect job for a fellow or junior faculty. It's something they can contribute and kind of carve out their own little area. What that meant for me was getting every page from our hospital sent to my phone as a text. As you'll see, 99% of them are not cardiac arrest. Usually it's that level 3 trauma transfer from down the street. But this way, at least you could respond when you see an arrest coming in, drive to the hospital, and get more reps in TE, get people used to it, and start getting some images.
And I think that's key to sensitizing everyone, as Andrew was saying, not just the docs, but also everyone else working who's going to be in the room, getting them used to the idea. And they'll get to the point where they're saying, oh, is there someone here who can do the TE for us? Because that's helpful, and I want that information. And it really is key to have that champion help build a cadre of people that can do this.
So in summary, the big takeaways really, if you want to start your program, are find your allies and then continue to reevaluate that. So at first we had no allies, and then as we started doing this, we identified 1 or 2 people that have become very helpful to us. So find your allies early, but then continue to reevaluate that. Plan and budget, if at possible. Try and do that with all your needs at once. Try and have a nice package to present to your chair. Write a clear protocol, have it laid out, have it public, have it shared, something you can lean on. Identify a leader that can kind of spearhead this and come in and put a lot of time into this to make it something that they see consistently, and then ready your team so that they know what to expect. Thanks for all the time. Any questions? We're happy to answer. Yeah?
How did you approach the conversation with your chair, the initial large investment with no return on that investment?
It's a great question. I'll kind of split that into 2. The first time we approached it was actually a grand rounds I did as a third-year resident about TEE that just kind of put a bug in his ear, and then we started talking about it more and more. And then in terms of return on your investment, I think there are some incalculable ones. It's the way of the future. It's very attractive to residents and fellows, and it's it's good for other departments to see as well. Critical care, they might be skeptical at first, but when they see that you're doing this, it's motivating to the rest of the hospital to see that you can do something cutting edge. So there are some incalculable return on investments, but I think you just have to have a clear conversation. There's plenty of data out there now to show that this is an excellent thing to be doing. So
the patient's first approach works both with chairs as well as with other services that may be like, why do you need to do this? The data are clear that this affects cardiac arrest care. So if you fall back on it's in patient's interest, that's always an asset. I think some of it is timing. So the chairs listserv over the past few years has started to rumble and send messages around. And if you're a chair, you don't like to be falling behind what your peers are doing. And so sort of saying like, this is becoming the standard at X number of places. And periodically someone writes that up about how many TE programs there are in development. So you can potentially bring that. And then if you're billing for your ultrasound program as a whole, you should be in the black based on your studies, both on the professional fee side as well as the technical, as of course. So assuming you are net positive for your department, making an investment potentially when a machine's up for purchase, you can make the argument like this is just part of a successful program. We are in the black. We need this to help develop, and it's a draw for residents and fellows, for sure as well too. Just the probe. They're more expensive than your standard transducers, for sure.
Initially, no, unfortunately. Ideally, that is the way to go. What you want is a lot of reps on SIM and then some exposure in the OR, preferably with cardiac anesthesiology or such. We did not have that opportunity at first. We've finally opened that door just in the past few months, really, where now our residents get some time in with a CABG patient in the OR to do these. But initially, we didn't have that.
That comes back to just figuring out who your allies are. And you really just need one, and I think we're so siloed downstairs, like we sort of make contact with people, but we don't have a lot of social time with other docs in the hospital in the way that if you're anesthesia, you're in the lounge with a bunch of surgeons, or if you're a hospitalist, I feel like they congregate in places and have more chance to chat with folks. Meeting people and figuring out who's on your side and chatting with them goes a long way in terms of getting some sort. Literally, it just takes a single person from a division or department that's doing this to help get you some exposure.
Yeah, I think we started by talking to the higher ups in each department and just got no. And then all of a sudden you find one young faculty that was just trained in cardiac anesthesiology that's psyched about teaching, and that's all you need. You just need one yes. So.
Within anesthesia, there's a real drift to get better at point-of-care ultrasound in general. There's increasing expectations from ASA in terms of what their residents learn. So if they haven't been in touch with you, I suspect they will, because they need transthoracic echo, they're learning gastric, they need some lung, and so there may be an opportunity to sort of collaborate and swap and get some exposure to the cardiac ORs for providing support for some of their training too.
And they also probably have a simulator you can use.
Yeah, which is key.
We're kind of ready to get our program up and running, and then our cardiac anesthesiologist was going to help us out a stroke.
Oh, no.
And so now we don't have anyone on that side, but we're supposed to be hiring like 2 more, but we don't have any say who we're hiring and if they're going to be helpful.
I think if you just
set the expectation when they get hired.
That is sort of like
your
predecessor had. This is sort of where things are going, and we're happy to and proactively say we're happy to support what you may need for your trainees and learners as well too from point of care scans.
Thanks everybody.
Appreciate it. Thank you for coming. We'll migrate upstairs for sauna games.